Hi, everyone. Thank you so much for giving me the opportunity to talk about my thesis. I'm really excited to be here today. So the title of my thesis was Planned Oocyte Cryopreservation, Past, Present, and Future. So oocyte cryopreservation is, of course, egg freezing. I do want to just mention before I start that many of the resources and studies that I looked at were really looking at women in particular, but of course, many of these issues pertain to all people who are capable of childbearing. So here's my abstract. Over the past decade, increasing numbers of fertile women have chosen to pursue planned oocyte cryopreservation to mitigate the effects of age-related fertility decline. And while this has largely been viewed as a large step for reproductive autonomy, there's been considerable discussion about the ethics of this procedure and particularly how it's been marketed to young women. So in my thesis, I reviewed the existing literature on planned oocyte cryopreservation, including its development, growth, costs, clinical outcomes, and utilization. I then explore some ethical arguments for and against the procedure, and particularly in the context of this kind of aggressive marketing environment. And finally, I then kind of conclude with an ethical framework for physicians to use when counseling their patients about oocyte cryopreservation. So just to start, a little bit of background about fertility decline. So we've all heard of this biological clock that's kind of counting down the days, weeks, and months till women kind of go into menopause. So the average woman's fertility declines around age 32, with a more accelerated decline around age 37. And this is because every month only one egg really matures, and that's the one that's ovulated. And then all of the rest that are kind of premature are just kind of die off through a process called follicular atresia. So while we're born with millions of oocytes, by the time we're 37, it's down to about 25,000. And with maternal aging, we see a decline in egg quality and a higher incidence of miscarriage, and also a higher probability that the eggs that are produced have chromosomal abnormalities. So with increasing age, we do see these mounting kind of obstacles for women hoping to become pregnant. So a little bit about the procedure itself. So the treatment consists of 3 steps: ovulation induction, egg retrieval, and freezing. So during this first ovulation induction step, a woman's ovaries are stimulated for 2 weeks through hormone injections. And during this time, they're also undergoing blood work and kind of routine ultrasounds. And then this culminates in the egg retrieval process. It's a procedure done under sedation through which a transvaginal ultrasound aspiration occurs. And then these eggs are flash frozen using a process called vitrification. So like many medical procedures, this comes with a host of side effects. So I've listed a few here. There's also some risks associated with the egg retrieval process itself, and again, of course, with becoming a mother at an older age. And importantly, 5% of patients will experience ovarian hyperstimulation syndrome, and less than 1% will experience a severe form of this condition, which can be life-threatening. So next, looking at the cost per fertility IQ, the average planned oocyte cryopreservation patient will spend between $30,000 to $40,000 on egg retrieval and storage fees. And of course, this number will differ based upon the number of cycles the patient undergoes and how long a time elapses between the point in which they choose to undergo the freezing process and when they choose to thaw. So over the past sort of 2 decades now, we've seen a massive growth in the fertility industry. And this is kind of owing in part to this procedure, but losing its experimental label and also having better freezing techniques. But in the past few years, we've seen tremendous growth of planned OC utilization. We see the number of cycles increasing by nearly 2 times. And then we've also seen a large growth in the number of fertility startups and insurance companies. Famously, in 2014, Apple and Facebook announced that they would begin covering costs for fertility preservation, and a number of large companies followed in their footsteps. So from 2015 to 2020, this number of companies offering egg freezing benefits increased by 13%. With this increase, we've seen advertising and messaging that's been sort of sensational and not fully transparent about the costs and the risks of this procedure. So in this one analysis, we see these common themes of messages about freedom and empowerment, the younger the better, stopping the biological clock, and insurance for the future. But rather, we don't see a lot of advertisements showing the costs of this procedure or even how clinically useful it is. So now looking at these clinical utilization and birth rates, we see a minority of patients are, well, first I should start off by saying that there's limited data on clinical outcomes, and that's largely because this is a new procedure and there's this inherent lag of about 5-10 years between the time a person freezes and the time they thaw their eggs. So take this all with a grain of salt, but existing data shows that a minority of patients return to use their eggs. We see that generally older patients are the ones who are utilizing their eggs. When looking at the probability of achieving at least one live birth from frozen oocytes, you can see the numbers here span from around 30%, 20 to 30%. And what impact does a woman's age have at the time? We see that this clearest demarcation of age 38, so performing oocyte cryopreservation past 38 is not as good as before. And so then I looked at these key ethical considerations. So potential harms to the patient include this financial cost, physical risk, and also psychological harm. So there's harms associated with thinking that you might be able to achieve parenthood at a later age and potentially delaying and then it not working out. There's potential harms to the future child, including limited data on long-term outcomes and less lifespan overlap with a parent. There's potential harms to society, including the overemphasis of genetic parenthood, changing these family planning norms, and diverting attention away from other structural changes like increased parental leave and childcare to support women who are undergoing childbearing in the workplace. Of course, there's this expansion of reproductive autonomy. We know that a woman's biological window for childbearing kind of completely coincides with this time when we're trying to achieve our educational and professional aspirations. So this, of course, increases that time period. And it also increases reproductive autonomy for single women and LGBTQIA+ patients. And of course, there's a consideration about justice. There's a prohibitively high cost, so this would only be afforded, this opportunity is really only afforded to people who are able to afford it. And of course, it might be a Band-Aid solution to a social problem. There's also additional ethical considerations in the context of this marketing environment. So we know that the marketing can be sensational and instill fear around fertility. There's a fear about coercion and aggressive marketing. And some have even argued that the option to pursue fertility preservation through one's employer might be coercive in and of itself, in that it may be implicitly implying that women should delay childbearing in their careers. Then I looked at the responsibilities of the counseling physician, mainly that physicians really ought to educate their patients on the really realistic costs and the probability of future benefit, on the data that exists and the data that doesn't exist. And they ought to present all options and to normalize the message that it's okay not to try to optimize one's fertility in this way, and to help patients understand that pursuing biological parenthood is one option among many. Then I proposed this ethical counseling framework, which came from kind of all of those considerations, which I won't go into too much detail here. So finally, my conclusions were that while oocyte cryopreservation presents an opportunity to mitigate the effects of age-related infertility and expand reproductive autonomy, it's also really important that we communicate about the risks, the costs, the data, the lack of data, and the messaging properly to patients and the public at large. And that all of these factors really compel physicians to engage in careful and values-driven counseling with their patients. And finally, that physicians should explicitly reject the message that biological parenthood is something to always be optimized when that might not be correct for all patients. So finally, I wanted to say thank you to the whole program and to my advisor, David Hoffman. And here are all of my references. So thank you, everyone.